Today we had the 5th summit to discuss the healthcare benchmark, and we focused on the governance and authority structure from 3 states. We had Mark Larson, who shared the perspectives from Vermont, David Seltz, who shared the views that Massachusetts took when developing their health policy commission, and we also had Dr. Bruce Goldberg, who led us through the development of the Oregon Health Authority. Hope you get to join us and listen to these highlights today.
Mark Larson is the former Medicaid director for the state of Vermont. He's now Vice President of Policy at the Center for Healthcare Strategies and provides leadership training for Medicaid directors across the country.
So, at the time that I was in the legislature and we were dealing with our reform bill, these are a couple of questions that we really struggled with that I hope may be helpful in your considerations. Again, I'll go back to that notion of the relationship between the policy development and the regulation. There's the who sets the policy and then who evaluates decisions based on those policies. We spent a lot of time looking specifically at this notion of the difference between an independent body versus a representative body. As we talked more about this, there was a really strong push in writing the legislation, and proposals would come in on a regular basis about, isn't it important that so-and-so is at the table and is a member of that board? And we really pushed back because the notion was that the board was going to be the place that we had coherent oversight over the entire system that served Vermonters. And we had some prior history where representative boards got bogged down to a point of inefficiency. And we really wanted to maintain an independent board that could make decisions that were in the best interest of the state and the system and Vermonters, and where folks were responsible not for representing some entity, but were really responsible for looking at the whole.
David Seltz is the first executive director of the Massachusetts Health Policy Commission, an independent state agency that develops policy to reduce healthcare cost growth and improve the quality of patient care.
You're going to hear from 3 states, and we all did this a little bit differently. There's no one right way to do this. And I'm a big believer in states being the laboratory. So however you decide how to move this forward, tailor it to your own state, to your own priorities, to your own stakeholders, but also learn from other states, because I do think that there is absolutely some lessons to be learned as you put this together. The board governs through consensus. I think we've had 5 years. We just celebrated our 5-year anniversary. I think in that 5 years we've had 1 no vote among our board members. So it really is a place where there is a dialogue and an effort to try to find compromises and work together to advance the goals of the agency. A few other things just quickly about kind of the structure here. So the board does appoint the executive director, that's myself, and I oversee the staff and run the day-to-day operations of the organization. Recognizing, again, very similar to Vermont, that while we have this independent board, we really wanted to be able to have connections with all of these important stakeholders. So it wasn't like we didn't want the perspective of the Hospital Association of the Medical Society. And so the law set forth that the executive director could establish or should establish an advisory council that I meet with regularly. And that advisory council was given kind of broad discretion to me in terms of who I could appoint to that. I have a 32-member advisory council made up of just about every different perspective that one could imagine in healthcare. And we meet about quarterly and talk about the priorities of the organization and get input.
Dr. Bruce Goldberg is currently a professor at the Oregon Health and Science University, Portland State University School of Public Health. He led Oregon's nationally recognized health reforms, transforming Oregon's Medicaid system to one based on a model of coordinated care.
We also know that a lot of what we contributes to our health, and I always lose my doctor union card when I say this. It's not about the doctor or hospital we go to. What contributes more to our health is our zip code, it's our social environment, it's what we eat, it's what we drink, it's what we smoke, it's what we shouldn't smoke. Social factors are a lot more about our health and our health status than our medical care. Yet, about 10% is medical care, but that's where 99.9% of the dollars go. So how do you start to focus on some of all these things? And this is where everyone goes, yeah, great, Bruce, but what does changing how care is delivered look like? And let me just tell you a quick story, because this, I think, exemplifies what changing care looks like. This is Malik. Malik is a 12-year-old boy, and he's got asthma. And Malik was going to the emergency room every month. Now, Malik had really good health insurance. He had a really great pulmonologist. He got every new medicine that had a Z and X and a Y in the name. I mean, he had it all. But he would keep going to the emergency room every month until he got enrolled in a new community-based program where we sent a community health worker out to his house. They helped look at what was causing Malik to wheeze. They actually removed some carpets from his house, helped pay the family pay for some new carpets, bought the family one of these new HEPA vacs that get all the dust out of the room, taught his family better how to use all these great medicines he was taking. And a year later, Malik was not in the emergency department once. Now, think about that for a second. I'm a family doc. I've taken care of thousands of Maliks. No one pays me for a community health worker. In fact, community health workers, when we started this, you can't even pay them. They didn't have a code to be able to pay them. In fact, I got perversely paid more. I mean, I got paid every time Malik was sick. I didn't get paid when Malik was well. So think for a minute how things would look differently if the charge was no child should ever have to go to the emergency room with an acute asthma attack. And that sort of is what changing care delivery is about. How do you create a system where we all work together to keep Malik out of the emergency room? And that means really thinking differently. It's not about having a system that pays for office visits. Or it's how do you start to create a structure where you have community health workers, you look at illness and prevention and community health in a whole different way. So to do that, we created coordinated care organizations. It was our belief that all healthcare is local, that you could draw a circle around a community, and it's about the people, the hospitals, the doctors, it's about everybody in that community. And how do you bring them together to do exactly this?
Thank you for joining us for today's summit. We look forward to having continued conversations. Happy to engage in ongoing dialogue. Please send us your comments on our white paper and our approach to looking at ways to improve healthcare in our state.